Okay, so let's go for the, what is it about the Schwartz round in particular that we can take into line management and team dynamics? So the question I'm assuming is probably coming from the, okay, that's happening on a ward and happening really at the direct patient interface level. How can we take the best principles when we're at times a step removed from that because we're a commissioning organisation? I think it's probably the context behind that question, Jeremy, that's helpful.
Yes, so I think the first thing to note is that there are things that happen when caring for patients that really take their toll on staff. And you can't always just expect someone, whether it's a nurse or a doctor or whoever it is, a caregiver, to come from a situation that has been difficult and expect them to move immediately on to the next thing. The pressure's there to do it, of course, but actually that's going to have more difficult effects in the long run if what that means is the staff are then carrying the baggage around with them, they're going to get burnt out more quickly. So actually taking a little bit of time to allow our staff to talk about what they have experienced. So sometimes it's as simple as just asking, are you okay? Do you want to talk about that? Even a 2-minute conversation can make a huge difference. This is what Schwartz rounds are trying to get to. They're enabling staff to have that space to reach that conversation in a confidential, no-blame environment. And that's what we need to ensure that all of our staff can do, so that when you, if you're a line manager in a provider organisation, you identify there's a particularly difficult situation going on, recognise that staff might need to take a little bit of time there to deal with it. Again, this comes back to the question earlier about how do we lead compassionately in a situation where there is so much pressure. And I come back to what I said earlier about reflexivity. Actually, there is a dividend from taking a little bit of time in the short term. It will pay off in the long term. So just that recognition that staff sometimes need that time and that chance to talk can do wonders.
I just sort of building that on a bit, we often talk about becoming a learning and improving organisation, don't we? Hopefully those of you who've worked with us over the past sort of 12 months or so will have recognised a desire to improve and learn from mistakes that we've made in some of our decisions or the way we've handled some of the situations that have confronted us. And I've chaired some of those kind of lessons learned type reviews, and some of you will have taken part in some of those. My reflection is we too often jump in those conversations. It's important we learn our lessons, but we too often jump to the facts of what happened here, what happened there, what didn't we do well here, what could we have done better, and actually taking a bit of time in those conversations to talk about how people felt in the heat of the moment when they were confronted with that decision or when they had to respond to that difficult situation would help us all enormously become better at supporting each other and improving as an organisation, a set of organisations.
Let's get into the conversation. Nikki, one last question there.
Thanks very much. I just wanted to ask a question about patient engagement in relation to this agenda, because one of the things that we know, despite the poor data that exists, particularly around BME patients, is that patients from certain protected characteristic groups have poorer experiences of healthcare than other patients. What my experience has been is that actually those patients, as has been said already, are our staff quite often, and also for those staff hearing about those patients and their poor experiences. So for example, if you're a BME member of staff or an LGBT member of staff and you hear about a patient's experience where perhaps they've had poor care as a result of their characteristic, or certainly it's been a feature, that has an impact on your experience of working for that organisation, because your sense is actually my organisation doesn't provide the right good care to this community, what does that say about my organisation? Therefore, what does that say about me working for them? So I feel like there's a really strong correlation between staff engagement, staff experience, patient engagement, patient experience, and equality and diversity. And I don't think we've talked about that this morning. And I think it's a really important point to hold on to. So I value the panel's thoughts on that.
Okay, so I absolutely 100% endorse what you just said. There are very definitely links there. I talked about some of those links, so I was talking more about how staff experience might affect patient experience, but the reverse is also true. Just going slightly academic for a minute, we look to see to what extent there is a direction of causation we could identify, and it seems that the staff will affect the patients more than the other way around, but it is still very much true that the other way around happens as well. One other thing that I didn't mention earlier is if we look specifically at the responses to the staff survey and the patient survey from black and minority ethnic staff and black and minority ethnic patients, we see just as strong links there. And in fact, the experience of all patients is linked to the experience of BME staff in a particularly strong way. And this comes back to what Yvonne quoted earlier about the experience of BME staff, the way in which BME staff are treated in their organisations, being a really good barometer of how good that particular organisation is. The same is undoubtedly true for patients, but it's just that we don't have quite such good data on the different experiences of the patients at the moment. But the work that has been done in that area, especially the qualitative work that interviews patients and understands their experience, absolutely backs up what you've just said.
Yeah, absolutely. And we have been doing a piece of work with one of the best organisations in the country on the res. And one of the questions was exactly that: how does it impact on patient care? What are patients saying? And it was really interesting because they came back with some data showing that patients were having a better experience, and what they were in terms of not staying on this mental health trust, not staying in hospital as long, going on leave much quicker, not actually having to be put into seclusion as often. But that obviously needs writing up, because the question you ask, lots of people are going to start asking me very soon. Give us the evidence and show us where this is happening, that patients are actually benefiting from the work that you're doing around staff. And we can say it, and from an academic perspective, it all stacks up. But people in the NHS always want evidence, and they want to know where these things are happening. So our job is to actually identify where it's happening, how it's happening, and to write that up so that all of you can hear it and read it and see it, and so on.
Great. We've got another question from the floor, if that's all right. So.
Thank you, Adam. I just felt that as a BME, I do want to say something. So my experience in the NHS, and I can relate to what Yvonne said about trying to knock on the door and get in, but I think one of the things that's helped me personally is actually having somebody who believes in you. And people might not believe this or not, but because of my experience, I haven't always been as I am, because I talk a lot, so people might think that's how I've always been, but I haven't always been that way. I've come in to do, like you said, Yvonne, I come in, do my job as best as I can and get out, because that was the relationship I had with my previous employers. I'm going to say, not because it's Adam, but then when Adam came to Brighton, he actually encouraged me to be myself. And in being myself, I actually have come out and been who I am, love going to work, do more than I should do, and those who work with me know the hours they do, but do more than I do, but because I love my job. I personally believe in the NHS, and the reason why I believe in the NHS is I am from Nigeria, and I know what bad healthcare is. Everybody else here doesn't know. Because there's having healthcare where you don't think about money and you just access it. In Nigeria, people die because they don't have money. So I would do anything for the NHS, but I wouldn't have done it if you didn't encourage me and support me to be who I am. So I'm not bashful about being a BME, but more importantly, and Adam doesn't know this, because of where I am now, being an exec in the NHS, I do have a lot of BME people come to me to ask me to support them to come out of their shell. And one of the things I would advocate for us to do is actually for people to be mentors, but you have to listen. It's not been an easy conversation sometimes with Adam, because he has said things to me that are uncomfortable, but those who know him know he will say it anyway. Where he will challenge me and try and get me to get rid of my negative experience, because your negative experiences stop you from moving forward sometimes. So he'll challenge me, and now I actually see myself as a butterfly, and I don't think anything is impossible. I just think it is the supportive environment and a mentor that enables people to come out of their shell and give their best. And that to me is the most important thing.
I thought you were going to give her a hug then, or take the
later.
fighter.
Take that later. The 5 of you. That's fine. Thank you for that. But back to business. So, are we speaking to BME staff in our CCGs to hear their views and learn from their experiences? Come on. If we ask the question, we sort of know the answer, I would suggest. We asked the question, so let's get an answer. Byron, you work with us now for a good few months.
Yes.
What's your take?
Well, if I may I transfer the question to the audience? Anybody here have BME staff in their teams? Anybody here? Hands up if you've got BME member staff in your teams. Do you speak to your BME staff to hear their views and learn from their experiences? That's the answer to the question. Thank you for sharing. So that means that we need to do better then, doesn't it? Based on what we've heard today, we do need to do better. Yes? Okay.
1 second, Byron. I think we need a bit of a better response to that, yes, I think.
Oh, yes, we do.
So do you want to ask the question again?
Do we need to do better in the way that we, as line managers and members of staff and colleagues, engage with our BME staff to learn from their experiences and hear their views?
Yes.
How are we going to do this? How are we going to do this? Because I have a responsibility. I'm Deputy Director for Inclusion, so I have a responsibility. But as line managers and colleagues, we also have a responsibility under the NHS Constitution, as employers of the CCGs we're employed in. We also have personal and professional responsibilities. So how are we going to do this? Well, I'm going to work with the Staff Equality Network to agree the ways in which we can do that through the network to better understand the experiences of BME employees within the HCCGs. That's what I'm going to do. I would like to hope that a similar commitment can be made from you privately to yourselves to do something similar as a line manager and a colleague. Is that agreeable? Yes. Okay, so when we have a similar type staff event in 6 months' time, and Adam randomly asked this question, are we doing this? We'll be able to say, yes, we are, because we've heard and witnessed our collective agreement to do so today.
Should we give ourselves that challenge? I like that. It's a 6 months' time, haven't you?
Yeah.
So 6 months' time, we're going to do something.
Yeah.
We're going to do something. I don't know what it is yet. We're going to do something. My team are freaking out about me giving an action. I can just feel it. We're going to do something where we're going to answer that question again, whatever it is, and we're going to put ourselves all on the hook for that.
Yeah.
I think what we need to agree with clinical chairs. Mind, put your hands in the air, clinical chairs. Brilliant. We're going to agree that we're going to have that commitment with our governing bodies too. Yeah. Right. So that in 6 months' time, we're going to come back and say we've got a better answer than what we gave going forward. Are we all committed to doing that?
Yes.
Yes. Yes.
Go for it. Of course you can.
Hi, I'm Corinne Green. I'm a HR business partner. and work for Coastal, who are an absolute great team. One of the things that I'd like to know about is how we create a safe environment for all staff to raise issues around people who are not compassionate leaders, and equally for BME groups to have a safe environment to raise issues about colleagues or managers. And also, how are we going to educate and raise awareness? Some people don't know, they are not interested, or they are not exposed to some of the issues that some of us have been exposed to. So as a group of CCGs, what's our commitment around training and educating our leaders?
All right. So I do know that within the CCG Alliance, we are doing a significant piece of training for all of our managers to help them and enable them to be the best leaders and managers that they can be. It starts with their values. It starts with their understanding of how to motivate and lead staff. It starts with helping them be able to have one-to-one conversations, formally and informally, about objective setting and target setting. It helps enable managers to build positive relationships with colleagues, so there's a trusting relationship. So the colleague might be able to come and say, well, I've had a difficult conversation, or I think somebody spoke to me inappropriately. How can you support me to deal with this? So, I mean, it's my understanding, and Terry can probably expand on this further, that this model will be shared with the other 8 CCGs and discussed at least. So that's what the organisation is doing. In terms of operating in the right environment. Okay, so I think I'm very fortunate. I speak about my experience. So I've worked in HR and OD for over 35 years and equalities, and I flit in and out of equalities because I've not always found a leader that is committed. So as an E&D or a manager in E&D, you can either have a job, as Yvonne spoke to, or you can have a vocation and an aspiration and a career. So since I've been here, I'm certain that Adam is serious about changing the values of the CCGs, that we put people first, we put our behaviours first, and we don't diminish on quality or what we're meant to be doing, but there's something about having good basic manners at work on a daily basis, irrespective of how I feel. So I manage my own anxieties, I manage my own stresses, and I engage with you in a civil way at all times, because number one, the NHS Constitution says I should. I'm a public servant. My bosses say I should. It's the right thing to do. And guess what? When I do, people generally engage back with me in an okay way. I feel better at work. I give more, and patients' outcomes are improved. And that happens. That is as real for a CCG as it is for a provider. So I wouldn't want people to divorce the fact that a lot of the data related to providers, and it doesn't relate to CCGs or commissioners. It relates to how we operate too. If we engage and treat people better and have the environment where people can safely and confidently speak up about poor treatment, then I'm certain that the organisation will be able to do even better things than it's doing now. But it's about making sure that message is repeated and repeated and repeated. It's putting our values are tested through recruitment, as Laura mentioned, and that we have got the backing of our managers to respectfully challenge poor practice.
Yes, the training and development and core training for everyone, yes, of course we're going to do all that, but just building on what Byron said, so we are the leadership community of our CCGs. There's nobody else who's going to change the culture, it's us. So every single one of us in this room needs to go back, learn from today, and embed that culture that we're all committed to putting in place, and challenge that behaviour, because only by each one of us doing that will staff begin to feel comfortable about talking about their issues, about challenging bad behaviour. If we don't do it, nobody else is going to do it. It's for us to change.
Thank
You have another question? Oh.
Adam, sorry, I'll just add one more point that's pertinent, I think. Our governing bodies are absolutely committed to supporting this stream of work. It's absolutely core foundation to us moving forwards as a team and really making a difference for our populations. So I will be expecting our governing bodies in the north, and I'm sure Elizabeth and David, I can see nods. I can't see where David sits. David, where are you?
He's gone.
Oh, he's gone. Oh, sorry, yes, sent him away. We'll be doing similar in the south. So what are we doing? Where is our progress? And we will absolutely 100% support the, if I've calculated it right, 6 months is 160 days, yeah? 160-day challenge on turning this around.
Very good. Fiona, question.
Hi, my name is Fiona Streeter. I'm from the two CCGs in the east of East Sussex. And it was a comment really rather than a question, because it's fabulous to hear the work that's been going on in the Alliance and in Coastal. And I think there's a real opportunity for us to work together and build on work that's been happening across all 8 CCGs. So I know that we've been doing work around National Inclusion Week, around values-based recruitment, around processes to raise concerns and enable people to talk to each other, to their peers, where they might not feel they can formally raise a concern. And I think there's a real golden opportunity for us to take each other's best practice and share that and learn going forward to build a really inclusive and compassionate organisation. So it was kind of an excitement about being able to do that together going forward.
That's wonderful. The 8 chairs, if you like, we had a meeting last night for various bits and bobs, but we have really forged great relationship with the 2 East Sussex chairs. And I think that reflects how the organisations are working in a much more integrated way across the patch as well. So I really welcome that, thank you.
Yeah, and I think to add to that, we're at a point in time, aren't we? So we set this conference off months ago, hadn't we? Long before I knew I would be responsible for the East Sussex CCGs, that's fair. And then we're going to do a conference on inclusion and then leave the other ones out. That felt a bit weird, didn't it, really? So that was sort of the conversation we had, if that makes sense. So I think we have to recognise there have been some great things in other CCGs going forward. I think we have to get us all to best in class together going forward. But it would have felt quite odd to be standing here with 5 CCGs today and you are back at the office and we're all going to march to the same rhythm going forward. And the important part is, yes, the 8 chairs have fully agreed to work in a consistent way on this, so I think we can happily catch up and get those things in the right place going forward. I'm noting the time and I'm getting a sense of rumbling stomachs for lunch. So before I do a summary, I'm going to just quickly check if there's any burning questions people wanted to ask any of the panel. We also need to, I think, make sure we have a response to each of these questions, if that makes sense. So we actually go back to all the ones we haven't got around to answering. What I was going to ask the panel, if I may, a personal reflection about advice you would give us all about what you think we need to do or we should take away from this part of the session, and then from that I'll then do the summary, and I promise you'll get to lunch if that's all right. So can we sort of, Laura, you've got the mic, to go first.
What should we take away? So many things, and I'll try and distill it. So, and I'll distill it in 2 words. Acknowledge, listen, understand, and commit to take action. And there's that bit about how the NHS is so hierarchical. I think maybe less so than some organisations, but I still recognise it as being there, and how we are all open to the conversation. I don't want anybody to feel they can't come into my little box in Crawley, I won't call it an office, and come and talk to me about concerns, and I know many of you do, and we should embrace and encourage that. I want people to be able to feel that they can come and talk to us and share any issues or concerns with any of the leadership team and be listened to and for action to be taken.
For me, I just want to build on what I just said. So I think it's sort of 3 words for me. Don't be passive. We need to all actively engage and model and lead this change, because nobody else is going to do it. It's for us to lead.
Indeed, and building on both of those 2, yes, acknowledge, listen, understand, and yes, don't be passive, but sometimes that means actually being proactive in seeking out what the experiences of people in your organisations are. BME people, not just BME people, but especially if you're not yourself from a BME background, trying to understand what the people who are from a BME background in the organisation are facing on a day-to-day basis.
Thank you. So all of the above, and to talk about the issue, start to talk about it, because white people struggle with using the terminology, calling people black. People describe me as a tall woman, kind of, you know, I'm a black woman. You know, start using the terminology. Nobody's going to worry about it if you get it wrong, but start talking about race, because it exists. And never say, I don't see colour. Never say it.
For me, one of the takeaway that's been reinforced again is that our personal style and the way that we develop relationships within our organisation and across the health system can impact on lives directly. They can impact on whether or not people die, or live or die, and they can impact on whether people or not have a good experience of the NHS, patients have a good experience of the NHS or not.
So, shall we show our appreciation to the panel? You gave me some comments. There's much I can say in summarising what we've all covered today, but I suppose my take home from what I've heard is I think we have to talk about this stuff first. Have to talk about it and find it an easy thing eventually to do going forward. That's clear. I'm really, really positive going into lunch because I think I felt in the room the acknowledgement of the issue. And there was a risk today that there would be less acknowledgement. Not that that was my feeling coming into the room, but when you put groups together, you just never know, really. So first of all, thank you for acknowledging the issues. That's really important for us. It would be also really easy for us to go that now Terry and Byron, off they go to write the plan. Because we like a bit of that in the NHS. We like a plan and a trajectory and a graph. We like that. It's really important that we actively are all part of that plan going forward, and that we're all really clear what our individual and collective responsibility is to achieve that as a group of leaders in the commissioning system. That's that. We have to ask our providers some difficult questions, don't we? I'm not going to ask them now, somewhere in the audience, bless them. But we have to ask the question. That's our job. We are commissioning the Constitution, aren't we? So why haven't we asked the question? Is it because we're scared to ask the question? Is it because we didn't even think to ask the question? But we're going to have to ask the question of everybody, and I will say this, including primary care. The whole of the NHS needs to have this question asked us, and we commission all of that. It's really important. And then really, the last piece is we are going to go on this journey together. Well, there'll be ups and downs with it, because if there's not ups and downs with it, we're not pushing to the point of being a bit awkward for us all. So it's important. But what's really important is we're all clear what we're aiming for. We are aiming to have a highly motivated, hard-working staff that want to be here. And if they want to be here, and they want to work really hard for us and deliver the right thing, the patients, the people in this room, the neighbours, the family, the friends that we discussed at the beginning when I first opened today, they get the better care. So, that's enough from me. We've got these sessions this afternoon. I'm going to get this wrong, I know that, but that's okay, because that's life. So we've got lunch in there. Byron has said to me, in a very polite yet wedding planner kind of way, he's slightly concerned about the number of you going to lunch, so can we just, there's enough food, I promise, but can we just phase it out a little bit, if that's all right? It's a very small room. Is that fair? And then we'll regroup back at 1:30. Byron, what's the key, where's everybody off to next?
Okay, so in this room, after lunch, we've got Paul Deemer. Is Paul Deemer in the room? Hi, Paul. Hi. Paul Deemer from NHS Employers, and he'll be talking to us about the Workforce Disability Equality Standard. The details have recently just come out this week. Is that right, Paul? So I think we're one of the first NHS organisations to be hearing about that detail. So that's for the first hour in here. After that hour, it's Mikhail Sanidas. Hi, Mikhail. Mikhail is from NHS England, and Mikhail has done some fantastic work in developing the sexual orientation monitoring information standard. And Mikhail's presentation will be showing us how that standard is helping improve patient care, patient outcomes for LGBT communities. And that's going to be in this room. We've got the reverse session in the function room. So Mikhail will go first there, followed by Paul. In the studio room, Dr. Habib Nakbi at the back of the room, and also Yvonne, will be running a session on workforce race equality standard, focusing on data for our region. Is that correct?
Yeah, focusing on what to do, action plans, and how to make things work.
Okay, and that session is going to be run at 1:30 and again at 2:30. Thank you, Ed.
Great. So before we close the lunch, can we give the panel another round of applause? Thank you very much.